RetinaRounds, episode number 196. Today we're revisiting a high-yield surgical topic, submacular hemorrhage displacement. Co-host Dr. Rahimy and I will walk through key steps of the case performed by vitreoretinal fellow Dr. Bertan Cakir. We highlight decision points in real time, review surgical and non-surgical management options, and discuss pearls and pitfalls when surgically displacing submacular hemorrhage. All right, Asan, welcome back to RetinaRounds. It's great to restart our conversations about interesting surgical cases. And this case that we're going to be describing today is actually your case, patient with a submacular hemorrhage from neovascular AMD. And some of your surgical decision-making, I think, was probably influenced by what was going on in the patient's fellow eye. So tell us a little bit about the patient and what you ended up doing.
Thanks, Pradeep. It's great to be back. This is a great case to kick this off with. It's actually a patient who's essentially functioning monocular. The fellow eye has extensive subretinal fibrosis from exudative AMD, and this eye of interest had already been managed on essentially anywhere from Q6 to 8 week injection intervals, anti-VEGF therapy. Name your agent. This individual's had all of them over time. And he incidentally had gone on systemic anticoagulation, and he presented at one of his injection appointments, and he had this acute onset, like massive submacular hemorrhage involving the fovea, and his visual acuity had been reduced to counting fingers acutely. So you have a lot of options in these cases. Some people could argue to just continue with anti-VEGF therapy and tighten the injection interval. Some people will sometimes do in-office pneumatics, potentially plus or minus injection of intravitreal TPA. We've heard some colleagues have good success to report on that. And then, one of the options that is at our disposal is doing a fairly urgent vitrectomy with planned subretinal displacement of the hemorrhage. And so I brought up all of these options with the patient. Obviously, he got an injection right there at that visit as well, too. But just given this is his primary seeing eye, he opted for surgery. He said, I want the best shot I can to potentially recuperate as much of this vision, and decided on surgery.
Yeah, no, I think that makes perfect sense given that this is his better eye. But one of the downsides of surgery, of course, there's always going to be some complication with surgery, but particularly with submacular hemorrhage cases, it's interesting. I think Jason Su and colleagues at Wills had a series looking at surgical outcomes in patients who have undergone surgical displacement of submacular hemorrhage and actually found a much higher rate of PVR and retinal detachment than what has been reported for other indications of vitrectomy, which I thought was a very interesting paper. Do you specifically talk to patients about that added risk within this particular subset of disease?
Always, if they're opting for surgery, the top things at the informed consent discussion are obviously risk of infection, they're phakic, risk of cataract progression, risk of recurrent hemorrhage, and failure to achieve those outcomes, and obviously a risk of a retinal detachment. Yeah, that paper by Jason and colleagues is well cited, and you're right. It does say the risk ends up being a little bit higher than I think what most of us had thought. Now, I don't know whether that's potentially due to peripheral pathology that gets encountered at the time of the vitrectomy that was otherwise unanticipated. I even recall a few of these cases in my career, even during my fellowship at Wills. During the part of that procedure, you encounter peripheral lattice or atrophic breaks and holes, and then it becomes an issue of how do you manage that, especially if it's inferior pathology. You worry about a much more elevated risk of redetachment during the post-op period, because it's difficult in that case if you're creating a large bleb to get good laser uptake and tamponade on the areas of interest, or is this just due to just being in there and displacing a lot of blood? Blood we know is extremely pro-inflammatory and increase the risk of getting PVR. I don't know, but it is absolutely, part of what we're discussing and with these patients when we're consenting them. And I think we all agree, if you look longitudinally over time, we're not doing vitrectomy for this indication as much anymore. That's actually one of my discussion points with the patient and family, is that we typically we're not in a rush to go straight to surgery here for this case. But I think given his overall circumstances, the decision made sense.
Yeah, that sounds good. So let's take a look at the case. So this is a phakic patient, and you're doing a 3-port vitrectomy here. Okay, so now we can see the hemorrhage here, and actually the hemorrhage is not sort of uniformly large.
Mhm.
Usually, intervention in these cases is going to be for patients who have thicker hemorrhage, whether that be pneumatic displacement or surgical intervention, whatever it may be. Fortunately for this patient, it looks a little bit thinner towards the fovea. So, despite the fact that their vision's now counting fingers, that's actually kind of a good sign, I think. And perhaps if this patient didn't have poor vision in the fellow eye, would you have considered doing a pneumatic in this case?
I maybe even just told them to stick with injections and see what happens. Anytime I see this, I'm inclined to just tell these patients, the array of options and let them pick. But absolutely, you're right. The extent of this hemorrhage is not, diffuse and substantial. I think it's more about the location of it and the patient's obviously the fellow eye status that push them to intervene.
So I see that you're doing a hybrid vitrectomy here. You exchanged one of the trocars for a 23 gauge trocar and now going in with the subretinal cannula. Why did you decide to do that?
The primary reason we did it in this case is our OR was out of the 25 gauge subretinal injector system that we typically like to use, which is it's a dork one. It comes almost on an injector, sort of, so to speak, where the subretinal aspect can be retracted as you're going in and out. But yeah, the 25 gauge platform of this was not available at the time, so we had to just swap out one of our trocars for 23 to do this.
And is this a 38 gauge, 41 gauge tip? Do you know?
This is a 41 gauge tip.
So choosing where to inject the TPA is something we should discuss. I saw that you or your fellow were trying first superiorly and now going into the inferior macula, where there's, I think, a little bit more space might make it a little bit easier, especially if your fellow's operating here to try to get into that subretinal space without potentially going too
You
deep.
can see that they just got pretty good access right there with that kind of fluid wave that just shot through. Yeah, and that's kind of the key is testing out a few spots. And I like them to go somewhere where there's a little bit more kind of meat, so to speak. Otherwise, you can see with this when you're indenting, you're just pushing really hard into retina and RPE. But we tested a few spots. We got a nice wave, and you're actually starting to see that hemorrhage, the fresh hemorrhage, is starting to already displace inferiorly where that bleb is.
Mhm. And what dose of TPA are you using here?
We used, I want to say 25. We kept it pretty dilute. I know some people will go up to 50, if I'm not mistaken, even. There's various, in vitro models and animal studies that suggest try not to go any higher than that, obviously. What do you usually use when you do your displacements?
Yeah, I would say so 25 I think is the highest where I feel comfortable that I'm not going to be putting the patient at a higher risk for toxicity. There have been people who've talked about 50 micrograms in point 0.1 if they're doing an intravitreal injection, in a pneumatic displacement. But when you're injecting subretinally, I think 12 and a half to 25 is good. I think the overall dose of TPA that you're administering shouldn't exceed ideally should not exceed 50 micrograms. So if you've got a concentration of, let's just say 25 micrograms in point 0.1, you just don't want the volume to be more than point 2 cc's.
Correct. And you can already see here, there's some nice inferior displacement of this blood. We went with the concentration was 12.5 micrograms per 0.1 cc. We wanted to try to get more volume in for the displacement. And the other part, we already moved past it, is the decision whether or not to administer intravitreal filtered air, which we did in this particular case. Our primary reasoning for this was I was somewhat concerned with this patient's ability to actually position appropriately. And in these cases where you do subretinal air, then put in your partial gas, the appropriate positioning post-op is actually for them to just be upright. And it allows for greater displacement of the hemorrhage, which is ultimately what we decided to do here. What are your feelings on that and whether or not to put any subretinal gas?
Yeah, I think it's interesting that I think the first report of that air bubble in the submacular hemorrhage case was actually just by accident. I think it was just it ended up being a trailing air bubble, and it ended up being advantageous in that case. And I think it makes good sense to do that. There are people who will do a sort of a cocktail of TPA, anti-VEGF, and then a little bit of a trailing air bubble. So you could have, let's just say you've got a concentration of 12 and a half micrograms in point 0.1. You could have like point 0.3 or point 0.4 of your TPA, 0.05 of your anti-VEGF agent, and then maybe another 0.05 of air, something like that. Uh,
Mm-hmm.
so. And I think also as you're injecting, aside from what you're injecting, it's how you're injecting. So location matters. We talked about that, and also going slowly, I think, is important. If you inject too rapidly, you do run the risk of maybe blowing out a macular hole. Obviously, you want to make sure that you're injecting into the subretinal space and not trying to force fluid into the sub-RPE space. And when you are injecting, you have a couple of options. One is you can have a skilled assistant push the plunger for you as you're holding it, or you could there's some special microdose injection kits that you can buy that'll hook up to your VFC module for your vitrectomy machine, and then you can use the machine to then inject the TPA into the subretinal space. Do you recall what you did for this case? Were you injecting while the fellow was
This
positioned?
particular case, I did the injection, but we have used some of the VFC assists, and I actually tend to like that more. I think it's just a little bit more controlled, as you said, and it avoids these kind of sudden surges of fluid coming in. Both
Yeah.
work though.
And I think it's going to be a skill set that surgeons are going to be more and more comfortable with as we start getting into the realm of gene therapy and potentially even stem cell therapy. This is the way in which we're going to be administering these agents. So
No doubt.
it'll be comfortable for surgeons as the years go by. So let's take a look at the postoperative outcome here. All right, so here's the post-op fundus photo. A really beautiful postoperative outcome here. Really nice displacement. Actually, it looks like I don't even see any residual hemorrhage here. Usually you'll
Yeah,
see almost like a crescent of dehemoglobinized blood, almost fibrotic blood pushed out towards the periphery, but we don't even see that in this case.
yeah. With patient, family, all of us were elated. I was pleasantly surprised to see that, and very happy for the individual. Obviously, I think that OCT is where you're seeing the preoperative scan.
Yeah,
The
so
next one,
here's the pre-op OCT, and even though it is a bit thinner towards the fovea, you can see there's a significant elevation there.
still
So
significant elevation. Yeah.
certainly doing something surgical here makes a whole lot of sense, even in the absence of issues going on with the fellow eye. Here is the patient's postoperative
That's this post-op month one OCT right there. So we're clear of any hemorrhage. We see the underlying CNV, a little bit of what David Seraph used to call a multi-layered sign, or kind of an onion ring sign there, so to speak, but fairly inactive at this point. And his visual acuity last I had seen was about 20/70, and his cataract has progressed quite a bit. So he's actually gearing up to get cataract surgery. We'll see where he lands, but
That's
so
awesome.
far he's very happy.
Count fingers pre-op to now 2070 and still has some more vision rehabilitation to go. It's really great. And then here's the patient's fellow eye, so you can see the discoform there in the left eye. Great. Congrats. That's a great case.
Yeah, thanks, Pradeep. Glad to share it.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.